opportunity to speak this morning, and it's exciting to be on a panel with these other giants of ophthalmology, so have patience with my little local talk. So this, I think, is a patient we all have, Mrs. 2020, let's call her. So your routine, uncomplicated, perfect cataract surgery patient. She's 2020, rolling out of the OR, and she comes in post-op. 1 week, she's good, she's happy, you're happy, everybody's happy. She comes back a little bit later, she's weaned off of her topical steroids. Now she has some inflammation, her eye's a little bit sore. You say, okay, let's restart the steroids. Then she comes back again, she looks good, you wean the drops. She comes back again, oh, she's got more inflammation again, you restart the drops. And this keeps happening over and over and over. Now you're several months out from surgery and you can't get her off these drops without the inflammation coming back. I'm sure you all have had those patients. I've had those patients. I know you do because I get those referrals. But certainly this is that cycle of inflammation after routine surgery, and it can be very frustrating because you expect this patient to have a good outcome, and it's months from surgery and they're not happy and you're not happy. So how do we break this cycle? So I'm going to focus first on why this happens and how to approach it, and then what we can do to treat it. So first we have to rule out the masqueraders, and the other speakers have already discussed some of these things, so I won't belabor the points. We want to make sure that the patient doesn't actually have some kind of chronic endophthalmitis, so look to see if there's any posterior segment involvement. Are there deposits on the IOL? Is there some tiny retained lens fragment somewhere? Also very helpful to gonio these patients to see if there is something hiding. And is the IOL in the right position? And consider ancillary testing like UVM to confirm. So let's say we've ruled out all those things, and this really is a patient that has post-op uveitis. There are three main reasons why this happens. One is because they actually had pre-op inflammation at some point, and that was unrecognized. Two, because they're a high-risk patient for inflammation, and the perioperative steroids wasn't strong enough for that patient. And three, no good reason, what we call idiopathic, so that we sound smart. Essentially, unrecognized pre-op inflammation. These are usually patients who have either a remote history of uveitis, and it may have happened before you even saw the patient for the first time. It could have been many years ago. They may be somebody who has a systemic autoimmune disease like sarcoid, but they don't have any known uveitis. They just have it systemically and it's under good control. Just because they may or may not have had it before doesn't mean they won't have it after surgery. Also, previous infectious uveitis, so patients who've had previous viral uveitis or toxoplasma, even if it was just chorioretinitis or previous TB uveitis, can develop inflammation after cataract surgery, even if they only had posterior segment disease previously. So what this is all about prevention is detecting these patients before surgery, doing a really thorough history and exam, checking the other eye, looking for the obvious signs of inflammation. Certainly if you see a PSCC cataract in a young patient, that's often a quick sign to consider a history of uveitis in the past. And also appropriate prophylaxis. So if the patient had toxoplasma chorioretinitis, they should be on toxoprophylaxis for cataract surgery because inflammation after surgery is very common in these patients. And the same with viral uveitis. And if the patient had systemic autoimmune disease, either increase their treatment or watch them very closely. Just because they don't have uveitis before doesn't mean they won't get it after. So inadequate steroids in high-risk cases. So really this is, who are the patients that are at risk of developing uveitis after cataract surgery? Certainly, as I just mentioned, the patients who've had it before, whether it's autoimmune or infectious, patients who have systemic autoimmune disease. I had recently myself have a patient who I operated on just a few months ago, had sarcoidosis, completely inactive, not even on immunosuppression, never had uveitis, and I thought, okay, I'll just put him on a little bit more steroid after surgery. 2 weeks post-op, he comes in with rip-roaring inflammation. I had to bump him up to every 2 hours. I had to do a Kenalog injection, and finally he's recovered. And that was a patient who really had completely indolent disease, but it really acted up after surgery. And as well, of course, patients who've had complex surgery or prolonged surgery, or patients who've had their surgery done a little too soon. The standard in the uveitis world is to wait for 3 months of disease inactivity before you do surgery, and that should be on 4 drops a day or Pred Forte or less. So this is not quiet because they're on Durezol Q2H and 50 milligrams of prednisone. They're quiet and stable on a low dose of drops. So if they're like that for 3 months, then it's a safe time to do the surgery and the risk of flare is much less. So this is my perioperative steroid regimen. I mean, everybody's a little bit different in how they deal with these things, but there are a few different things. There's obviously drops. There is, you can use mild drops through to Durezol. You can use IV Solumedrol intraoperatively. You can use Kenalog injections or Ozurdex or intravitreal injections. And you can use oral prednisone. So my combination of these depends on how high I think the risk of flare is. And that's a little bit based on my sense of the patient, having seen them before, and also what their disease is. So if it's a low risk of flare, I'm likely to just increase their steroids before surgery. I might do a little bit of an injection intra-op, just a little bit of subtenon's Kenalog, and I will taper their steroids very slowly after surgery. If they're more of a moderate risk patient, then I might put them on Durezol or a low dose of prednisone. I will often use IV Solumedrol, 250 to 500 intraoperatively, and then potentially add some type of injection. And again, I will give them high dose topical steroids plus potentially prednisone and drops and taper it very slowly. If they are high risk of flare, I will throw the book at them. I will do everything. And that really helps to prevent complications post-op, because these patients who are at high risk develop cyclitic membranes, they develop hypotony, they develop phthisis, they develop CME, and there's significant risk of losing vision. So, the idiopathic ones, these are the ones that make us pull out our hair. There's no good reason why they have inflammation. Now, I'd say 90% of the patients that I see are in the first two groups, where really it potentially was preventable, and there was something that either we didn't catch or we didn't treat in time. But there's certainly about 10% of patients where there was no reason to do anything differently, and yet they have prolonged inflammation. I would say, I think in our GTA, in all the different practices I work at, I see this most commonly in patients who are of African descent, and typically an elderly female from the islands who's of Afro-Caribbean origin. I don't know what it is about the genetics that makes that common, and I looked it up actually. There's one ARVO abstract from several years ago that documented post-op uveitis is about twice as common in African Americans compared to Caucasians. But other than that, it hasn't been extensively studied. But if you think about your patients who have this lingering uveitis, it often falls into this demographic. So I think these patients that are truly idiopathic, you don't know why it's happening, and it won't go away, deserve at least a basic workup. Nothing crazy, but a basic workup. So basic labs, maybe some additional labs based on the exam findings and on the history. So my basic workup for uveitis, and this isn't just for post-operative, this is for pretty much all anterior uveitis, I will do syphilis serology and a chest x-ray. I will order some basic blood work because I might put them on prednisone or immunosuppression, but I don't think you always have to do CBC and lights and creatinine, but at least syphilis and a chest x-ray. And then I will add the additional testing based on, based on what I think might be the problem. So if it's granulomatous or non-granulomatous, or based on what I think is going on, I will add the additional testing. So just a few basic blood tests, and I have caught, I've only been in practice for 7 years, but I have found 6 elderly patients with syphilis, neurosyphilis, diagnosed because of lingering chronic inflammation after cataract surgery. And obviously treatable, you have to put your unconscious bias away about how they acquired that, but just because the patient is senior, don't always check syphilis anyway. So how do we break the cycle? And this is really, a very simple strategy. How do we stop the inflammation? As I said, 90% of the time, I think we can avoid it if we've detected those patients in advance and we have triaged them appropriately with the steroids around the time of surgery. But let's say they're either one of those idiopathic patients or is just not going away. Really, it's really simple. Treat the underlying cause and then continue the topical steroids. So I say keep on with the steroid force, don't stop till you get enough. So essentially, these patients just need more steroids. There's a population of patients, often this typical Afro-Caribbean patient, where they need 6 months of topical steroids after routine, uncomplicated cataract surgery. For no good reason. It's just how that person is, that's just how the demographics are, and just keep giving them the steroids. If the inflammation is very bad, consider a little anterior subtenon's Kenalog injection, even 20 or 40 milligrams. That's easy to do in the office, but don't stop the drops. My strategy sometimes is to just not see these patients when the referral comes in, to just wait 3 months to see the patient. By the time they get to see me, they're better. And that's because they just took the drops for that much longer. And essentially, I find this works really, really well. Some patients just need the drops. Maybe it's just Predforte, BID or TID, and a very slow taper over several months. Of course, if the patient has steroid-induced glaucoma, that's a different scenario. You have to adjust the drops accordingly, but otherwise I find that works quite well. So in summary, you want to rule out any masqueraders. You want to really try and avoid the problem altogether by looking for underlying causes before surgery and detect which patients you think are at high risk and give them appropriate steroids around the time of surgery. But if you are stuck after with just several 6+ months dosing of low dose topical steroids, really without trying to taper, will solve the problem in the vast majority of cases. And thank you very much.